Welcome to the Advancing Surgical Care podcast, brought to you by ASCA, the Ambulatory Surgery Center Association. ASCA represents the interests of outpatient surgery centers of every specialty and provides advocacy and resources to assist them in providing safe, high-quality, cost-effective patient care. As with all of ASCA's communications, please check to make sure you are listening to or viewing our most up-to-date podcasts and announcements.
Hello, and welcome to the Advancing Surgical Care podcast, brought to you by the Ambulatory Surgery Center Association, or ASCA. My name is Mark Wainner, and I'm the president of ASCA and the host of this recording. My guest today is my friend and fellow ASCA Board member, Alfonso del Granado, and he will be joining me in just a moment. Alfonso is the administrator and chief executive officer of Covenant High Plains Surgery Center in Lubbock, Texas. I've asked Alfonso to spend a few minutes talking with me about the challenges of managing anesthesia in the surgery center setting today. As healthcare providers know, but others may not, hospitals and surgery centers and the physicians who practice in them bill separately for their services. Accordingly, many anesthesiologists have practice independent of the hospital and surgery centers and have full discretion where they work. Still, not enough anesthesiologists are practicing today to meet the growing demands of surgery centers and hospitals. It's been a bit of a perfect storm, with all types of physician groups, including anesthesiologists, being acquired by large health systems to serve their facility needs exclusively. On top of that, a large number of anesthesiologists decided to retire during the pandemic. And despite these shortages, our medical schools are simply not graduating a sufficient number of anesthesiologists to meet the needs of surgical patients in every setting. At the most recent meeting of our ASCA Board of Directors, we were joined by Manny Bonilla, the Chief Advocacy and Practice Officer of the American Society of Anesthesiologists, or ASA, for a very productive discussion about improving these circumstances for both surgery centers and anesthesiologists alike. As part of our conversation with Manny, Alfonso shared some of the management techniques he is employing today to better utilize anesthesiologists within the facilities that he oversees. It was a particularly informative discussion that I thought would be worth revisiting on this podcast. Hopefully, others in the surgery center community will find it beneficial as well. And I'm pleased that Alfonso is joining me today. Alfonso, welcome to the podcast.
Mark, thank you so much for having me here.
Great. Alfonso, when you spoke at the ASCA Board meeting, you talked about some very practical methods of scheduling and getting the right payer mix of patients. And that obviously is very important. And we will get to those topics. But I'd like to begin asking you to discuss how you collaborate with anesthesiologists to create a unified approach. Can you tell us more about this experience?
Oh, absolutely. In the past, anesthesia surgeons and surgery centers often had a contentious relationship. Surgeons thought anesthesia should just do their jobs and put my patient to sleep. And so there was always a little bit of tension and a little bit of hostility. What we've done is to reframe our perspective on our relationship. We view our anesthesiologists as part of the care team. And as a result, we are planning each day, planning each case, taking their needs and their perspectives into consideration. We're all in this together today. And I think that was a bit of a mental change and a perspective shift that was essential for us to be able to establish the types of relationships that we needed in order to be able to move forward in this new environment.
All right. Thank you, Alfonso. We need to take a short break here to hear a message from our podcast sponsor. Stand by, and we'll be right back.
This episode of the Advancing Surgical Care podcast is brought to you by AmSurg, a national leader in the strategic and operational management of ambulatory surgery centers. AmSurg partners with more than 2,000 physicians and health systems and more than 250 ASCs operating in 34 states. Learn more by visiting amsurg.com.
Alfonso, before the break, you were talking about how you collaborate with your anesthesiologist. Talk to us now, if you would, about how you educate and collaborate with your practicing physicians and surgeons so that they're fully bought into your management techniques.
Honestly, Mark, it's not revolutionary. It is a natural evolution of something that surgeons have understood from the beginning. In the past, it was you were limited by the number of operating rooms. And since COVID, you're limited by the number of nurses and surgical techs. And now today we are limited by the number of anesthesia care providers. So when we are scheduling cases, when we are assigning resources, the number of anesthesiologists and the types of care that they can provide. For example, not every CRNA can do a block. These are just additional factors that we have to take into consideration. Once we got our surgeons to understand that perspective, that it's not us and them, but it's rather all of us together, they bought into it very quickly. Surgeons are smart people. And once they understand what the reality is, then they're much more likely to become an asset in your relationship management with the anesthesia care providers. Honestly, this is helping us tremendously. We were running some very inefficient rooms, 1 or 2 cases, because the surgeons figured, well, nurses are here, techs are here. I could throw on a case and at least I'll make something that day. But with the cost of anesthesia of it being so high, it's now impossible to have that kind of an attitude. So even founding partners who had blocks going back decades are being asked to put that case at the end of a day or stack it somewhere in the middle of the day. And they are being incredibly supportive and incredibly understanding. They know that this is not an easy thing, and they appreciate how much work everybody's putting in to get these cases done at all. And again, now we're making much more efficient use of our time and staff and resources.
Thanks, Alfonso. I appreciate you mentioning CRNA. Of course, I mentioned anesthesiologist, and I know a lot of centers use anesthesiologists and CRNAs or some combination of the two, or even maybe just an all CRNA model. So when we talk about these things, we kind of are talking about anesthesia providers in general. But let's talk a little bit about your actual work days and how you schedule procedures to maximize the days efficiently for both your surgeons and your anesthesia providers.
Yes. So we operate using certain rules of thumb that I think are common to many surgery centers. Typically speaking, a surgery center will say, well, 3 procedures, 3 general surgery cases will pay for a room. And we also look at it from the same perspective with regards to our anesthesia care providers. We need them to have a profitable day, because if they're making money, then that lowers or eliminates the subsidy that we have to pay out. So that makes us more efficient. We have 2 surgical centers, different sizes, different case types. So pretty much every day we're looking forward over the next week. I wish we could look forward more than that, but most of our cases are booked within a week. So we look forward through the week. We then negotiate between the centers and among the surgeons if there is a day where we have a crunch. We have 8 points of service and 13 operating rooms. So obviously we're going to have to make some compromises. And sometimes it's a surgeon at one center, sometimes at another. There are competing interests, of course. You may see that an orthopedic surgeon wants to put on a big case, but a GI wants to put on 8 small cases. And in those circumstances, it's easier to move 1 case than it is to move 8. And from an anesthesia perspective, those 8 GI cases actually pay fairly well. So if I had to choose between 8 GI cases and 1 large ortho, unless it's a total, I would actually go with the GI financially. But we maintain a balance as well with the surgeons, right? We need them to be able to do their cases. And if I know that if there's a surgeon who has been bumped several times, in fact, I have 1 ENT who was bumped 3 times to the end of the day, I'm going to bend over backwards to try to get them that 7 a.m. start next time, because they can't always be bearing the brunt of it. It really is relationship management just taken to an additional level, an extra dimension, if you will.
Thanks, Alfonso. When I hear you talk about that and the different centers, I'm hearing that this is really a center by center discussion. There are no 2 centers that are just alike. There's no one size fits all strategy that a center can take to meet their needs and meet their needs of their providers and anesthesiologists. A little bit earlier, we were talking about the patient payer mix. I've heard from some of our members in the ASC industry about having to, not take certain cases, Medicare in particular, because I think it's very well known that Medicare reimbursement for anesthesia is extremely low. So it takes the right payer mix in order to make a center work. There's no secret that the reimbursement for Medicare, Medicaid, and commercial insurances vary quite a bit, even among the same procedures with government, the two government payers, Medicare and Medicaid, often being the least generous of the three. Can you talk a little bit about how these payment differentials impact your scheduling and what you can do to achieve the right payer mix on any given day, week, or month?
Yeah, so unfortunately, Medicare is a little bit over a third of our volume, so we can't make a blanket exclusion for Medicare cases. So what we have done is looking at it case by case and understanding reimbursement rates for Medicare for different types of procedures. We've experimented a little bit here and there with limiting anesthesia for certain case types. For example, for a couple of months, we did not provide anesthesia to our ophthalmologists. And that was also a very difficult discussion. They had to get CPR certified, and some of them had to go back for monitoring sedation because they hadn't done it in so many years, some of them not since residency. But we put an extra nurse in the room to monitor the patient. The ophthalmologist was supervising, available if there's an emergency. And what we found after 2 months was that, again, for our payer mix and our configuration, the way our centers are structured, we actually lost money for the anesthesiologist during that period because we don't have the room so well stacked and so tightly structured that we could just afford to send them home after, let's say, the morning's ENT cases are done. By putting on 3 or 4 or 5 ophthalmology cases to follow, we found that the extra revenue actually contributed to a better bottom line. And significantly too, we're talking 6 figures. So every center, like you said, is different and going to have to analyze their finances and their anesthesia group's finances very carefully to find the right balance of coverage for the types of procedures that they're doing and payer mix that each procedure type brings. Obviously, ophthalmology has a higher Medicare rate than, let's say, ENT. So that is going to vary quite a bit from one center to another.
Great. Thanks, Alfonso. When I hear you talking, I'm hearing a lot of collaboration between your centers and your anesthesia providers, really having to understand that anesthesia model, understand their pain points and the challenges that they have with the way that we're currently scheduling, understanding their payment structure and how they get paid for different cases that your doctors are bringing to the center. And that varies quite a bit from payer to payer and then even from region to region. And then probably just most of all, just transparency with each other in order to really truly collaborate, to have that win-win approach to this.
We put our cards on the table, and to their credit, so that our anesthesia group. We had not had a collaborative relationship in the past, so obviously there was a little bit of lack of trust at the beginning. But we did our own analysis on costs and revenues. Our management company did third-party analysis, and both of them came within 1% of the numbers that the anesthesia group was reporting. There was full transparency, and that won a lot of trust between us. And so we are equally transparent with our finances and our needs for maintaining profitability. I'm going to give you just a quick example here. It's going to be a little high on numbers, but this is the level that every center needs to be at to be able to determine what's the right mix. We need 8 points of service. That's the minimum that we require to be able to operate. And that means 8.1 CRNAs and 3.4 anesthesiologists to supervise them. That's so that you have coverage for vacation and sick time, of course. At 8,000 cases per year, we're only generating enough revenue to cover providers. So that subsidy has to cover the backups, the vacation and the sick leave people. Even a small, efficient, single specialty center would have trouble covering an anesthesiologist on straight Medicare. So for example, if you have 3 cases per hour times 6 hours, that's 90 base units plus 24 time units at $20 a unit. That's what Medicare reimburses. It's about $500,000, barely enough to cover one anesthesiologist and definitely no backup, no PTO, no sick coverage. You would have to have high volume and high consistency in order to be able to maintain profitability at that ratio. Now, if you had 4 rooms and let's say they were covered by 4 CRNAs and 1 supervising MD, you would have 216 supervision units plus for which you'd collect an additional $1 million. So $3 million total. Then yes, you can run it. You can have an operating surgical center with pure Medicare and pay for anesthesia. But it's nearly impossible to be that efficient and that consistent every single day, stacking your cases front to back, every single room efficiently staffed. So for most centers, there's going to be a little bit of pain. Now, you had mentioned the payer mix. Obviously, if it's straight Medicare, it's going to be difficult or nearly impossible. But if you have some mix of private pay and Medicare, then it starts to do a little bit better. For us, the challenge, again, every day is making sure that our surgeons and our anesthesiologists are able to call it a profit.
That's great, Alfonso. I appreciate the background on that. When I think about some centers, especially some single specialty centers, if you're an ophthalmology center or a cardiac center, you're probably seeing 70, maybe 80% Medicare, and at $20 per unit for the anesthesiologist, that's, extremely low reimbursement for them. Conversely, if you're at a GI center, maybe you only see 30% Medicare, or orthopedic center, maybe only 20 or 30% Medicare, and the rest is commercial. So really understanding your payer mix, understanding the anesthesiology model, how they get paid, how much commercial business they have versus Medicare business is really important to the equation overall. So like I said, there's no one size fits all in this discussion. You really have to understand it, be willing to collaborate with your anesthesia partners, be transparent with them, share numbers, talk about your pain points in order to work with them to come up with a solution.
I completely agree. It really comes down to collaboration. If you don't have that, you're not going to be able to succeed.
Great. Well, hopefully this podcast will help some of our members and listeners find ways to address their anesthesia issues and concerns. Alfonso, I want to thank you for your service on the ASCA Board, for your many years of volunteering on behalf of surgery centers and the community. And thanks for spending time with me today. The challenge presented by the shortage of anesthesiologists and anesthesia providers is not going away anytime soon, which is why we need members like you to continue sharing ideas and best practices. I know you have a passion for the surgery center model, and I know your contributions are greatly appreciated. Let me wish you and your family and everyone listening a happy and healthy holiday season.
Thank you, Mark, and to you as well, and to obviously all our listeners. It's a pleasure and a privilege.
Now, before concluding, I would once again like to thank and acknowledge our podcast sponsor, AmSurg, a leading ASC management company with more than 250 ASC partners in 34 states. To learn more about AmSurg, visit amsurg.com.